Wow, welcome. So good morning, everyone. Welcome to the first annual Self-Advocacy in Healthcare Conference. We're delighted to join us and hope you find the material being presented engaging, practical, that you believe with the tools to begin your own self-advocacy journey in what is undoubtedly a very complex medical environment, care environment. So I'm Stephen, as my announcer should say, and I'm co-executive director and COO of the HIV Aging Research Project. We are in our 10th anniversary this year, celebrating 10 years. We're very happy. This is a brand new conference for us. We're producing this conference in partnership with the Healthcare and also with Serrano and the City of Palm Springs, who have helped finance this. I will do my donor pitch at some point, so don't run away. We will continue to feed you throughout the day. That's what happens when you put a nice Jewish boy in charge. There will always be food, but you won't be able to leave. Okay? We'd also like to thank our other community partners joining us today. First and foremost, the Mizell Center, which continues to be an amazing partner throughout the year. So thank you, Rob and Hector, and especially their staff and volunteers. Also, the absolutely amazing volunteers from Gay for Good who are with us today. They brought 6 of their finest to help us. And additionally, we have representation from a lot of community organizations. We have the LGBTQ Center here. We have Jewish Family Services, almost. Brothers of the Desert, the Transgender Health and Wellness Center, the Alzheimer's Organization, Cheeky Charity, Palm Tree Clinical Research, and Triangle Care Management. And of course, my co-workers, who I want to thank, Jeff, Jim, and Christopher, who work tirelessly throughout the year so that we can produce events like this. We meet today on the traditional territory and current ancestral lands and homes of the Agua Caliente Band Pueblo Indians, a federally recognized Native American tribe based in Palm Springs. We recognize, honor, and pay respect to them as the traditional stewards of the lands and waters on which we are now present. We honor the Agua Caliente and other indigenous caretakers of these lands and waters, the elders who lived here before, the indigenous today, and the generations to come. Let's do a little housekeeping. I have to get my flight attendant. Bathrooms are to the right and left outside the door. Look at the little sign, whether it's a boy or a girl, or if you're confused, just go into any of them. Really care. Okay. Should an emergency occur, you need to run out. Exits are there, and to the right and left when you go out the door. So stand, get up, scream like a maniac, run out. Don't block my way. This is a weapon. Photography. If you do not wish to be photographed or recorded during the presentation, please sit in the second row back. This whole thing is going to be recorded. It's going to be posted on our website, and it will also be posted in our social media. So your image will live. If you haven't noticed, on your chair, there is a survey. If you would turn in the survey at the end, you'll see there's actually a raffle ticket, so hold on. Actually, you don't. I have the other half of the raffle ticket. Just turn in your survey, and you might win an Amazon HD Fire tablet with cover and keyboard for turning in your survey. So we will do that. Make sure you fill out the entire thing. Just don't put your name. So that's this. You will notice the bag we have provided has a loop sleeve inside of it that has all the information that's going to be presented today, as well as some useful documents for you to take home. And each of the presenters will tell you about those. There's also a fancy schmancy highlighter pen in there so that you can make notes. You'll notice two volunteers our gentlemen from Gay for Good who are in the side aisles. If you have a question during the presentation, please wait for them. Just raise your hand and they'll hand you a microphone since it's being recorded. So please do that. Just don't call out because we won't catch it on mic. So let me tell you a story. So my dad had a favorite joke, and it went like this. This guy, he ends up at the pearly gates, and he's standing there in line with all these other people, and there's this guy in a long robe walking back and forth, and he's got like one of those things on his head and a stethoscope and a tongue depressor, and he's looking at everybody's nose and ears and throat, and he finally turns to the guy behind him and he says, he's going like up and down the aisle, checking everybody. And he turns to the guy behind him and says, "Who is that guy?" He said, "Oh, that's God. He thinks he's a doctor." So, in all transparency, I am the son of a man who was an attorney since he was 21 years old and practiced medical malpractice for 50 years until he died. Don't get all nervous, you providers. He was a good guy. He actually did a lot of work protecting children who were injured in birth. And we have a stack of letters from his patients, clients, and stuff. But, suffice to say, my childhood was a little more interesting than most. Instead of Legos, we had like body parts that would show up in our house. Not real ones, like not like, Happy Normal in a box or anything like that. But we'd have like a giant foot or a giant ear or a giant like half a body. I actually liked the spleen. I knew nothing about the spleen until it came into our house. So those were our like essentially. And actually, I think the ear was my favorite. Overall, it was a great education. But you never wanted my dad to speak to any of your doctors. I was in the hospital for the very first time, and my father made a point of letting the doctors know what he did for a living. So, God forbid you said you had a headache, you would be in for like a brain CAT scan, And I mean, who could blame him? I would if I was a doctor, So, not surprisingly, the four of us, my siblings and I, were taught to speak with our doctors, always respectfully, but never giving up until we were satisfied with the answer, and being vigilant and understanding that our healthcare was a partnership with our doctor, and we were in control of the information. And if we weren't happy, then we'd have to examine whether that's the doctor for you or if you're asking the right questions. So I'm hoping that in some small way, my father passed away just before he retired, and what he wanted to do in retirement is exactly this, to be a patient advocate. So in some small way, I hope we're honoring today, Papa T. So without further ado, I'd like to introduce Dr. Leo Moore, who drove up here from LA. And, well, you didn't have Coachella traffic, really. We thought you were. Dr. Moore is the Medical Director for Clinical Services at the Los Angeles County Department of Public Health. He is dedicated to ending the HIV epidemic and reducing health disparities in marginalized communities. He has both a Doctor of Medicine degree and a Master of Science in Health Policy and Management. Dr. Moore is also a certified HIV specialist and holds a diploma in international business and legal medicine. So, if you will, please welcome Dr. Moore.
Good morning, everyone. So excited to be here. I always love being here in Palm Springs. And can we just give a hand for HIV Aging Research Project? Honestly, I think this was such a great idea around self-advocacy and health advocacy and patient advocacy. It's so important that we, know how to advocate for ourselves. That's me, guys. So today, the title of my talk is Empowered People, Navigating Healthcare with Confidence. And so for our agenda, I feel like Steven's done a really great job with the introduction. So we'll go to the Hippocratic Oath. We'll talk about that. Patient rights by law in California. Some green flags versus red flags. Is your provider a good fit? Recognizing trusted online sources for health info, which is really important because there are so many ways that you can be given misinformation and disinformation these days. Health screenings by age, and then some closing thoughts and time for Q&A. So why is this important? When we think about patient self-advocacy, we know that it leads to patient satisfaction. Also, when we know that people feel what we call self-efficacy, or feeling that you have all the tools that you need and the ability to follow your provider's recommendations, that also leads to patient satisfaction. We also know that your engagement with your healthcare can lead to better healthcare and outcomes. So living longer and healthier. So patient self-advocacy is really critical for ensuring that you're able to live the longest, healthiest life that you can. All right. So what is the Hippocratic Oath? So it's a traditional pledge that's taken by physicians that outlines the ethical principles of medical practice. And so it's named after Hippocrates. And so he's an ancient Greek physician and the father of medicine. This was written about 2,500 years ago. So really long time, right? And for this oath to still be something that we as physicians and other healthcare providers take regularly. I took this oath in my white coat ceremony at the start of medical school, and then also took it again at graduation. And so I'm actually going to read the Hippocratic Oath to everyone. I swear by Apollo, the physician, and Asclepius, and Hygeia, and Panacea, and all the gods and goddesses as my witnesses, that according to my ability and judgment, I will keep this oath and this contract, to hold him who taught me this art equally dear to me as my parents, to be a partner in life with him, and to fulfill his needs when required, to look upon his offspring as equals to my own siblings, and to teach them this art, if they shall wish to learn it without fee or contract, and that by the set rules, lectures, and every other mode of instruction, I will impart a knowledge of the art to my own sons and those of my teachers, and to students bound by this contract and having sworn this oath to the law of medicine, but to no others. I will use those dietary regimens which will benefit my patients according to my greatest ability and judgment, and I will do no harm or injustice to them. I will not give a lethal drug to anyone if I am asked, nor will I advise such a plan. And similarly, I will not give a woman a pessary to cause an abortion. In purity and according to divine law will I carry out my life and my art. I will not use the knife, even those upon suffering from stones, but I will leave this to those who are trained in this craft. Into whatever homes I go, I will enter them for the benefit of the sick, avoiding any voluntary act of impropriety or corruption, including the seduction of women or men, whether they are free men or slaves. Whatever I see or hear in the lives of my patients, whether in connection with my professional practice or not, which ought not to be spoken of outside, I will keep secret, as considering all such things to be private. So long as I maintain this oath faithfully and without corruption, may it be granted to me to partake of life fully and the practice of my art, gaining the respect of all men for all time. However, should I transgress this oath and violate it, may the opposite be my fate. All right, so I'm going to stop there and see what are some themes that you all heard. First, I will share that In more recent years, we do use a more updated version of this. So I want to start with that. But this is the oath kind of translated as it was written. Any themes that you all hear in the oath? Sure.
They put the different gods and I love that they put the different gods and I don't think they said goddess, but still, I do like that. Do they now update it with different gods, and do they still use that because of where we're at today in society? It's a little.
This is a great question.
Yeah.
So the one that we currently use doesn't even speak about the gods. Period. Like it doesn't start with that part about the gods. It kind of skips down to hold him part. So I think that part just has kind of been taken out, as well as the part around abortion has also been. Any other themes that you heard in the oath? Is administer no lethal drug? It is that is still there. It is, and I think you're thinking of like euthanasia, right? Which is still controversial. Yeah. Right. That is a key thing, patient's privacy. Yes, and one that we will talk more about. I saw another hand.
Call it. Oh, thank you. Going to a physician and being diagnosed and forced with a diagnosis and then prescribing a medication 10 times stronger than was shared by the patient with the doctor. I don't know what that would follow.
So being overprescribed medication. Right. So that they're.
Here's something about the cost of care.
We'll say there was not a reference to cost, and we know the cost has definitely been rising.
This gentleman brought up a concept that reminded me there's really nothing in there about second opinion. Like in America today, we see, hopefully most people are getting it out there. That's very common to seek a second, maybe even third opinion. I'm not sure that was.
You're right. That theme was not in there. Oh no, you go ahead, and then she'll be next.
A reference to do no harm.
Yes. What's interesting is that people usually say first do no harm, but it does not say first do no harm, but it does say do no harm within. Sorry.
To go back to your question, what I perceive as the overall theme is that the patient is in charge, and it's between the two of you, and the doctor is the one serving the patient, not the other way around.
Yes, that's a major theme. It's a major theme. And I'll talk about that more, but also patient autonomy. So being able to, for me as a provider, to tell you the risks and benefits of a treatment, and for you to then decide the best treatment for yourself based on what I've shared with you about that treatment and alternative treatments.
So when you mentioned the part about I will not use a knife even to take out stones, I'll leave it to someone else. To me, that actually does sound like getting a second opinion. And then another theme I noticed is that the doctor takes it upon his or her or they themselves to treat their patients as if they're just as valuable there.
So I will say what they meant by that part about taking out the stone is making sure that we're practicing within our scope of practice. So I am an internal medicine physician. I will not be taking out your gallstone, And I definitely agree with what you were saying about family. Also, they talk about the importance of treating your professors like family, the people who taught you medicine as well, to hold them in high regard. You're next.
You have to correct me if I'm wrong.
Mhm.
When the oath is talking about treatment, that's an obligation to treat. And what if they need a referral to another doctor or another place? That is required. They cannot leave you to the street because they don't
Mhm.
have the answer,
Mhm.
right?
No, I agree with you. That's just not in the oath. But yes, definitely.
It's not in the oath.
It's just not in the oath from 2,500 years ago.
Okay. Well, I propose an addendum.
Is there anything there that relates to the modern legal concept of informed consent, which has been disregarded in recent history?
Mm-hmm. Mm-hmm. So not in the oath, but it's an additional modern theme that we're going to talk about. So I think this is a perfect moment for us to move forward. So key themes of the Hippocratic Oath: holding teachers of the art of medicine in high regard, doing no harm, as we discussed, treating patients to the best of one's ability and limited to one's scope of practice, as I was mentioning. I heard confidentiality from Ron over here, maintaining patient confidentiality, and also avoiding exploitation of patients was another key theme. Some of the additional themes and more modern themes of medical practice include patient autonomy, as I mentioned, social justice and health equity. So making sure that everyone has access to quality care and recognizing that there are some who are going to need more assistance to get the best outcomes as well. Lifelong learning. And so this is beyond board certification, but also ensuring that we're regularly learning about medicine and the art and the practice of medicine throughout life. Uh, agreed, including one of my certifications is in lifestyle medicine. So including thinking about the foods that we're eating, exercise, kind of the foundational parts of medicine that were really there before there were, physical pills, right? Us making sure that you're getting your sleep, that you're eating to the best of your ability, moving your body. Hmm. Well, the thing that I try to even keep in mind about many medications is that we know many of those medications came from plants as well. So there, are plants that then we saw some of the benefits of those plants, and those were incorporated into some medications. So there is still benefit of some plants and other alternative medicine approaches as well, which can be complementary to Western medicine. So cultural sensitivity and inclusivity. And so really thinking about your patient, their background, and ensuring that you're creating a space where everyone feels comfortable to receive care. And then the last one I'll say is well-being. So physician and healthcare provider well-being. We definitely saw a spike of suicides during the pandemic of our providers. Our physicians, our nurse practitioners. Yeah, we saw because a lot of us go into medicine thinking that we can save the world, thinking that we can save everyone, and during that time, there were just particularly for those who were working in the ICUs, the emergency room, there were just so many people and so many deaths that were happening, and it felt overwhelming for many of us, and for some of us they ended their lives. And so I've even seen within my department and conversations with other colleagues about creating space for our providers to have time for self-care. So, and also our health department workforce as well, having time for self-care. So well-being time, if it's 30 minutes a day, time that you could do meditation, or you could go for a walk, or so ways to try to build in some self-care, recognizing that we're carrying a lot, and I think during this time many of us are carrying a lot, right? And so that self-care, I think, is important not only in medical practice but in our lives. All right, so we're going to talk about patient rights by law in California. And so there are three main components of legal protections in California. So there's the California Health and Safety Code, and we have the California Department of Managed Care, and the California Department of Insurance. So the California Health and Safety Code was enacted in 1939 and combined laws that were already on the books for public health, sanitation, making sure that our streets are clean, environmental safety, making sure that our air is clean, that the places that we work, live, and play, that we're not being exposed to environmental toxins, healthcare regulation, so ensuring that that the appropriate safety mechanisms are in place for healthcare, and then building and fire safety as well. So I'm going to go through a few of the California Health and Safety Code laws. So first, patient privacy in medical records. So ensuring that patients have a right, that they know that they have a right to access and obtain copies of medical records. Facilities must respond within 15 days to requests for medical information, and they must protect confidentiality of your personal health information as well. And so this includes not only your primary care provider, but also your specialist, if you go to the emergency room, etc., that you will be able to access and must be able to access your records. Informed consent. So this is one that was raised when we were talking about the Hippocratic Oath. So patients must be fully informed about the risks, benefits, and alternatives before any medical treatment or procedure, and know that you have the right to refuse treatment. The next one is a patient bill of rights, and this is for hospitals and other healthcare facilities. So they must have a bill of rights posted and ensure that patients in licensed facilities have rights to dignity and respect, freedom from abuse or being neglected in that space, participation in care planning. So this really goes back to what we were talking about with patient autonomy, so that that they are a participant, that you are a participant in your care, privacy and confidentiality, and the ability to file complaints without fear of retaliation or being retaliated against. The next one is the Emergency Medical Care Code. And so this is for hospitals with emergency departments. They're required to provide screening and to stabilize anyone with an emergency medical condition, regardless of insurance or ability to pay. So you may have heard of people going to the hospital in an emergent situation, being stabilized, and then being transferred to another hospital. That's to ensure that people aren't just allowed to die, right? It's to make sure that they're able to be stabilized and safely transferred to a hospital that will be able to care for them based on their insurance or lack of insurance status. Non-discrimination, so protecting against discrimination in the delivery of healthcare services based on race, gender, religion, disability, sexual orientation, or other protected classes within the state of California. Advanced directives in end-of-life care, so supporting patient autonomy in making decisions about life-sustaining treatment, and ensuring recognition and respect for advanced healthcare directives. And so when we think about advanced healthcare directives, thinking about at the time that you're in a medical emergency, how you want to be treated. Do you want to receive full life-saving procedure, or would you want to not be resuscitated, etc. Right to file complaints. So patients in healthcare facilities have the right to file complaints with the California Department of Public Health, or CDPH, and the facilities are legally obligated to respond to the complaints, and CDPH then will investigate more serious claims. Now we're going to move on to the California Department of Managed Healthcare. So this department regulates health maintenance organizations and most Medi-Cal managed care plans. And so that's the majority of Medi-Cal plans. And when we think about health maintenance organizations, you can think about your Kaiser, Blue Cross Blue Shield, Aetna, different plans within those companies. Some of those companies also will have preferred provider organization plans too. So your plan would say if it's an HMO or a preferred provider organization plan. I'll talk a little bit more about preferred provider organization plans on the next slide, but a bit about HMOs. When you think about your HMO, it's like a one-stop shop, meaning that you are preferred to get all of your care within network. So including your primary care doctor, any specialists that you need to see, nutrition, what have you, all in network. And out of network is usually much more expensive. Whereas with a preferred provider organization, you're able to go really to any providers, and your insurance will cover. But the premium for those tends to be higher. So back to California Department of Managed Health Care. They handle complaints and ensure compliance with state consumer protection laws, and they provide help via the Help Center for Appeals and Grievances. The California Department of Insurance regulates preferred provider organizations, or PPOs, and fee-for-service plans offered by traditional insurance companies, and they handle insurance fraud, licensing, and other complaints. We're going to move on to green flags versus red flags. Is your provider a good fit? So I'm going to share some green flags, but then I also want to hear from you all what you think of as green flags for your provider. What makes you feel that you're with someone that you want to continue seeing? So some of the green flags are listening without rushing, explaining things clearly and welcoming questions, being culturally sensitive and inclusive, discussing options collaboratively, and respecting patient autonomy and boundaries. What do you all think are some additional green flags that you've seen with providers that made you feel that they were a good fit for you?
When my provider didn't know the answer, he said he would look it up and get back to me, and he did. So that was really...
That is a great one. Because there's often this thought that we are supposed to be seen as knowing everything, and I think that actually increases the risk of errors, right? So I prefer to say, hey, I'm not sure about that, in the same way that your provider does. Let me look it up. And also another important thing you said is that he followed up, right? In addition to looking it up, he followed up with you and shared what he knew. Another thing about that we often do is what we call a curbside, where we will call a colleague who's a specialist and have a conversation with them about it. So then that way we're able to get back to you with a full answer, about your question. Thank you. Ron up here had a comment.
So my primary care physician went to bat for me because within my HMO there was specialists that provide outside. So it's going very soon.
Yeah, that's a great one. I'll also add to that a provider who ensures that prior authorizations are completed in a timely manner. I think that's a big one. What was your hand up, sir? No? Okay. All right.
As a recent, my provider at Eisenhower went above and beyond his scope of physician by listening to me, and even though he only knows me like not even a month, he was able to advocate and send Medicare or Medicaid, I'm not sure which of the two, for in-home support services, which none of my other experiences even went close to that.
Going above and beyond, I think, is important. And also, I feel like he was listening to you to know what your needs were, right? And that starts, honestly, at the first visit. Is the person listening? Or does it feel that they have an agenda that they're trying to get through in a set amount of time? Because, that's one thing I had to learn kind of early on in residency, is that you walk in the room and maybe you have some things that you want to talk about. But let's put a list together based on the things that the patient wants to talk about, a few things that I think are important to remind you about, preventive screenings, things of that nature. And let's tick through those together. But let's first start with the things that brought you in, the things that you're most concerned about. Priority setting, definitely. And I recognize for many of our providers, it can be challenging because of the short amount of time. But at the end of the day, if you're leaving the space uncomfortable or unsure about what the plan is or unheard, then really it was a waste of 15 or 30 minutes, in my opinion, because you're unlikely to actually follow up and complete that treatment plan because you have questions that maybe you didn't have time to get answered. And it could also lead to you not taking medication or taking too much medication, what have you. A lot of room for error when there's not time for people to ask questions and get their answers.
So I have a test for clinicians. I like for them to and expect them to ask me about my sexual.
How's that test go? No, I'm just wondering how often that test is passed.
Yeah.
Mm-hmm.
Okay. And then I'll give them a slide, and then I tell them the real test is who wins.
I mean, I will say a follow-up test that I would ask is that I would be thinking of is, do they ask what type of sexual practices that, what type of sex you're having to make sure that they're actually ordering the right tests and things of that nature as well? Because I think that's an area that a lot of providers are uncomfortable with or deprioritize, because they're like, oh, I'm thinking about high blood pressure. I'm thinking about diabetes. I'm thinking about some of these other components, but sexual health, is an important component of overall health.
Well, they don't get to your part. Barely get to the sex part. And then the next part is really sexual. They stump. It just basically stops at the first one for the most part. I think to myself that and so I say, well, now this is what I do. And my comment about this is what I do, and then don't wince when I tell them. Actually, test is indeed those steps fall after you wince. That's not
I agree. Thank you. We'll take one more, and then we're going to move on to our red flags.
Just lastly,
I'm sure you guys have some of those too.
I wanted to piggyback on what you said at the end about the doctor giving a plan for the patient so that they can follow a plan and be comfortable with that plan, that they communicate it effectively. I guess maybe this is going to be the red flag. They do the opposite. The patient goes in and they are denied what they shared in an adverse situation, which is never reported to appropriate authorities, and the patient not receiving the appropriate attention by law, APS, social services, because that was never acknowledged by the
so you're saying lack of documentation, that they're not documenting what was
actually
said?
rewording the documentation and omitting it completely.
Okay. Yes, that's definitely a red flag.
By the entire.
Yeah. We'll count that one as our first one, which is, I'll say, even more grave than, some of the ones I have here, like dismissing your concerns, pressures you into treatment versus talking about all the options with you and giving you the opportunity to decide which treatment is best for you. Poor communication or lack of transparency, judgmental behavior, and unwillingness to consider second opinions. Any other red flags that you all think of? Laura?
Time management. I try to always get first thing in the morning because of germs for me. And I've gone to doctors where I'm supposed to be, it's like 8:30, they've been open for 20 minutes and they're already 4 people behind. And so for me, that means that they're looking at us as numbers and they're not concerned about my time. Their time's more important and their money is more important.
I understand that one. The only thing that I will say that can sometimes be a challenge is that we go into a room and we think we're going to be able to be done in a set amount of time, and there are other concerns that a patient has. So, yeah. So I think on both ends, it's can we give providers grace, but can we also look, what is the pattern with this provider? Because it can't be that every time you go, that they are running behind. It might be a time management issue, as you said. Sometimes it's more of an issue of, oh, this patient needed more time, or maybe this patient needs to be sent to urgent care from primary care. We do sometimes have those situations that put us behind. Yeah.
I would say also that, a lot of times, and I've spoke to my own physician about this, is that, you might be scheduled and it's a 15-minute appointment or 20 or 30 or 40. A lot of times, depending on the healthcare institution and your insurance, the doctors are limited by, you've got 15 minutes. It's not that they want to give you only 15 minutes. It's that that's being defined by the healthcare institution they work for and your insurance. And so, I guess what I'm saying is sometimes we just need to give our doctors a little bit of grace because they're not always completely in control of the time, as opposed to, not having good time management, which is a different thing. She just called me a sucker.
So I think that's why I'm also saying there are multiple factors involved in that. And I will say in our clinics, we really advocated for at least 20 minutes, but some people may not even feel the difference in that 5 minutes, right? And so we're always, oh, okay, all right. Oh, go ahead.
So one of the other things is really about the practice, the structure of medicine, how medical students are trained, and then through post graduate medical education is this slippery slope, which is very slippery and fast, is the fact that testing and medications become almost requisite for many, 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 many things.
I agree with you. I think in medical school, there's not nearly enough training about lifestyle medicine, as I mentioned, about nutrition, about even talking about exercise and being able to put together a prescription for diet and exercise, for sleep, etc. I think about, when I was in medical school, I want to say there was like a module of maybe a few weeks for nutrition, but I feel like, that really should be the base of training. Those. And I'm going to just share with you all what the 6 pillars of lifestyle medicine are, because I've said that a few times. So, physical activity, nutrition, sleep, stress management, avoidance of risky substances, and stress management. Those are the 6 pillars. And so, for me, I've incorporated that into my practice. So, not only thinking about medications and testing, but also thinking about, how are you kind of meeting those different components of lifestyle? Because there are many conditions that are reversible and treatable with lifestyle change. So, we tend to, even in medical school, when we're starting a person with diabetes, the first thing that it will say is lifestyle change, right? But many providers are not comfortable with lifestyle change, what exactly it takes to talk through, a diet, what it takes to do that food history, have them keep a log, etc. So the patient tends to be started on metformin from the beginning, for example, tends to be started on a diabetes medication. So I will say that if it is a condition that is reversible or treatable, to ask your provider in the same way that the gentleman in the back said he asked his provider and they had to get back to him. It's the same thing that you can do, is ask your provider, are there other lifestyle changes that I could make that could help improve this condition?
I just want to make a comment on the lifestyle medicine. I'm a community health worker at a clinic, and one of our roles is to have patient education. Since 2024, there was a new law that passed that CHWs were able to be billed by Medi-Cal. And what we have to do is do patient education regarding like chronic diseases and lifestyle changes.
Mm-hmm. I think that's really great that now it can be billed for Medi-Cal, right? And unfortunately, we know money talks, and if there's a way to bill for it, then they'll hire more community health workers, right? So now you're able to do that. And that gives a foundation that the patients have, so that when you do meet with your doctor, then that time that you're spending with your doctor can really be focused on the conditions, and you then can, speak with a community health worker to talk about those supportive pieces. But I feel like without that community health worker in place, and that provider does need to do that education, right, to ensure that those lifestyle changes are being put in place so that they're not working against the treatment plan for the condition. I saw another hand.
Yeah, this is just going back to red flags, and a big one for me is not being willing to discuss options. And I'm one of those people that, something comes up, cancer, whatever, I research it and find out things. And I've been in situations where, the doctors dismissed an option that I looked at, and then someone else looked at it and found out that the treatment they thought they were going to do wouldn't be appropriate because of what they found through the tests that I wanted to have done. So, open to listening to the patient's concerns and very exploring options.
Agreed. Thank you. All right, so I think that's a perfect segue into empowering yourself to make a change. So knowing that you can switch providers, call your insurance company or search for providers on their website. I recommend always requesting your medical records before you switch providers, unless you're, in a network like Kaiser where, it's all within the same. But if you're going to from, one provider practice to another to get a copy of your records, keep one copy for yourself and provide a copy to that new provider. And also know that you can request a second opinion from a different healthcare provider if you aren't satisfied with the first diagnosis or with the treatment recommendations. Recognizing trusted online sources for health info. So here are some signs of a reliable versus unreliable health site. Many reliable health sites end in .gov, .edu, or .org. I will make a plug here, though. My website's a .com, and there's reliable information there. So, so just because it's a .com does not mean that you won't get reliable information. But in general, look for .govs, .edu, or .org. Transparent authorship and sources, so citations, ways that you can read the references if you want to go back and read the article, are important from where that information originated. Updated regularly and medically reviewed content. So those are some of the reliable signs of reliable health sites. Unreliable, having sensationalist headlines. I think this is a big one because especially in this day and age, and I even find this with health influencers and sometimes even with health journalists on major news publications, they're looking to get you to click on it. They're looking to get you to interact with it. So it goes far in one direction or the other versus being like practical and centered. And to me, that is a major red flag, because they recognize that if they were to be practical with their headline, it wouldn't get as many clicks, and so really finding sources where you feel that the information that you're getting isn't causing like a reaction when it comes to health information specifically. Of course, in this day and age and other things that are happening, we're going to have a reaction, I will say. But as far as your health information, it should not be sensationalist. It should not be making claims, like being able to end autism by September. No author credentials or citations, pushing products or treatment without evidence. All right, so these are the health screenings by age. And I start with teens. So you will notice that many of these are the same throughout. So I will highlight those that are new. And on some slides, you'll see some that are pinkish color. Those are for women. And some that are bluish color. Those are for men exclusively. So for teens 12 to 19 years old, Alcohol and drug use. Blood pressure screening actually starts around that time as well. Cholesterol, hearing, obesity, HIV and sexually transmitted infections, vision screening, and mental health. I'm only going to call out the new ones. So some of the new ones here for men, monthly testicular self-exam, and for women, cervical cancer screening. In the 30s, some of the new ones, I noticed maybe my highlights are gone, but colon cancer screening if family history of colon cancer screening, of colon cancer. In the 40s, breast cancer screening starts. Cervical cancer screening would have already started, and then prostate cancer screening in Black men due to increased risk for prostate cancer. We do diagnose prostate cancer earlier, and it tends to be in a further stage at diagnosis in Black men. So at the age of 40, prostate cancer screening is recommended. In the 50s, let's see what's new here. Lung cancer screening for smokers. So for those who have a history of smoking or those who are current smokers, for lung cancer screening. Let's see. And then go back. Just wanted to mention here colon cancer screening for everyone at the age of 40. So for those with a family history, it was 30. For those with no family history, screening starts. Okay, we talked about these. Make sure there are no other news there. 60s. Note that cervical cancer screening goes until age 65. A new one here is abdominal aortic aneurysm screening. So that's an ultrasound that's done for smokers. And then in the 70s, there aren't any new screenings here. So just some of those screenings that are continued. A few themes here. Sexual health screening was throughout life, as well as mental health screening throughout life as well. As I mentioned, colon cancer screening from 30 and on. And then around 50 for the lung cancer screening for smokers. A few okay. Abdominal aortic aneurysm. Oh, no. So it's a large vessel, and it gets an aneurysm is when it gets kind of blown out. A part of it expands. And when it expands, it increases the risk of you developing a blood clot in that area, and that can travel, and could travel to the brain, could cause a stroke, and
basically begins in the abdomen.
It does,
and it can get to the heart. Okay, wow. How did they screen for that?
It's a ultrasound that's done, and it's only for people who have a smoking history, and by smoking history, I mean what we call a 20-pack year smoking history. So that's a person who may have smoked a pack a day for 20 years, for example, or smoked, let's say you smoked 2 packs a day for 10 years. So then that would be a 20-pack year history.
Right. So they do get that on the basic form, basic survey paperwork, But I'm concerned. My biggest question is secondhand smoke. What?
So we don't have recommendations around secondhand smoke for these screenings, unfortunately.
Well, more research. Let's research.
Yes.
Thank you. I have heard it can be more dangerous, when it's repeated, and I have.
There is risk. There is risk there, but I'm saying that there's not a guideline around getting these screenings for secondhand smokers. I agree with you that there is a risk for continued secondhand smoke exposure.
Okay, well, let's research that.
What about anal cancer screening? It's distinct from colon cancer because people think it's often the same.
Yeah, so currently the guidelines for anal cancer screening are for people living with HIV currently for that screening. And that screening can start as early as when a person is diagnosed. So there's not like a age start for it. It starts as early as when the person's diagnosed, and I want to say it's every 2 years for that screening.
And then what about for other MSM who aren't positive, or women who actually have the highest rates of or highest diagnoses of cancer?
Unfortunately, there is more research is needed as far as a clear guideline on that one. But we say it again. Sorry. Mm-hmm. Mm-hmm.
Okay, so what can you tell us about former smokers who perhaps have been smoke-free for 10 years?
If you had a 20 history, regardless of ever.
Uh-oh. Okay.
Ever, we recommend
Thank you
that.
so much.
Mm-hmm. Mm-hmm. 20 is the magic number. I multiply the number of packs by the number of years. If you get to 20, get the screening. Mm-hmm. All right. So some health advocacy tips. Keep a personal health log, which I thought was great. It's in here already. So if you go to section 3, thank you so much for creating that. I'm sure she'll talk about it, but this is a great way for you to be able to keep a personal health log. Know your family medical history. And this is one that I'm often telling my patients, and I'm telling people very early on to ask your family members, ask your mom, ask your dad, ask the people in your life about what diseases run in the family, right? So that way you have that information, and really helps with determining which screenings might be needed. So even when we think about colon cancer screening, as I talked about, starting that in the 30s versus starting in the 40s, and then as well as for prostate cancer, we know that knowing that history also helps when it comes to starting screening earlier, and for other diseases as well. So getting a family medical history is important. Scheduling your annual wellness visits. Now, there is a bit of controversy around if the wellness visit should be annually or if it should be every 2 years. I'm a person of the thinking that I reach out to my doctor at my birthday every year. And, I usually will send a message on the portal and say, hey, my birthday just passed, which I would like to be, usually I tell them exactly which screenings that I want, but you can, but you can also just say it's, my birthday is coming up and I want to make sure I'm up to date on my screenings. Can you order those screenings for me, or should I schedule a time with you? So that is a great way and a great reminder for you to get those screenings. So whether you decide every year or every other year is up to you. But if you're a person like me who may forget if it's every other year, then maybe you go with every year. Ask for copies of your results. So if you're not getting them in a portal, ask for copies and keep those copies for yourself as well, for your own records. And some closing thought. If you feel something, say something. So remember that you know your body better than anyone else does. And so if you have new pains, increased shortness of breath, dizziness when you're standing, any calf pain, increased confusion, you notice you're losing weight, but you're not exercising more or haven't changed your diet, those are some signs that you should see a provider soon. And don't be afraid to ask for a second opinion if you're uncomfortable with the treatment plan that's being presented to you.
Could I speak for a minute?
Yeah, sure.
With that annual wellness check, I've had to ask for that. I thought that was strange that I would have multiple appointments during the year and not have what I felt like was a real physical. And to top that off, I had to ask for a prostate exam. I'm 73 years old. That wasn't even part of the exam. I had to ask for it. That was beyond.
Yeah, I will say that that's a challenge I found across the board, is that unfortunately every provider is not going to make sure that all of the screenings are done in the timing that they should be done. Unfortunately, like we all go to get different training. We all may have different priorities, right, for your visits. Maybe the providers focus on some chronic medical conditions and so what have you. So I think there's definitely room for improvement, but also that's an opportunity for self-advocacy during this time as well. So if you're not seeing an annual wellness visit being scheduled for you, ensuring that you are asking for that annual wellness visit.
I just feel like I have a big mouth. Based on what he's saying, if we are part of the Medi-Cal or lower
It's
end,
covered, yes.
lower end of thing, the annual is covered.
Mm-hmm.
Thank you. And what is the most difficult cancer screening to prompt them to order for you? Most of my family has passed from different kinds of cancer, and I just wondered, in your opinion, what is the hardest one to get just a real rushed GP, to get,
I think the hardest one, just from logistics, is colon cancer screening, particularly if you're getting a colonoscopy. Just making sure that they get you connected, and there's usually is a wait to get your colonoscopy, and you have to take the prep and everything. You have to drink the prep for that. So that's the one that I'm like, it takes a bit more back and forth just to ensure that it gets done. But some practices have a very clear path for it. You ask for it and they get it scheduled quickly. Others you may have to kind of push to make sure that it gets done.
Right. And last question: pancreatic cancer screening. What's the latest on pancreatic? Is that still one of the most difficult, the pancreatic cancer, to detect early?
It is difficult to detect early, and we don't currently have a screening for pancreatic cancer.
Thank you.
You're welcome.
Prostate cancer screening, there seems to be a lot of fuzziness about that, of whether people should have a PSA test, whether they should have a digital exam, and what you do with that. And there was a couple of years ago, a lot of saying, no, we're screening too much.
Well, I will say that the PSA is a standard, and that the digital rectal exam can be helpful as well. But it should be done after the blood has been drawn for the PSA, because we do know that pressing on the prostate that happens during the digital rectal exam can cause an increase in your blood level of prostate-specific antigen, or PSA. So, if your provider is first getting your blood drawn, right, for that lab, and then doing a digital rectal exam, then it can help, because the digital rectal exam can also show them that maybe your prostate's enlarged. So maybe it's not cancer related, and maybe it's just BPH, or benign prostatic hyperplasia. Hypertrophy. And so being able to do that digital rectal exam can give them some additional information. Currently, the guideline is every 2 years for a PSA. And as I mentioned, it starts around age 40 in Black men, and around age 50 in other men.
How far along in terms of diagnostic results regarding cancer before one should be able to have a PET scan?
I'm sorry, could you ask the question one more time? Because I think that might be individualized. Go ahead.
I say, how far along should your diagnostic procedures indicate that it's time for you to have a PET scan? My experience is they usually wait too long.
I don't think that there's a one size fits all for that I can say. I will, because also I'm not an oncologist, but what I find is that as far as doing additional imaging, usually after there's at least been some tissue that's been collected that is concerning. So, a biopsy that's been done that is concerning.
Yes, health
sorry.
health screenings. I didn't see anoscopy on here, which is especially important for gay men.
Yes, you're right. Anoscopy was not on there, and I'll tell you one of the reasons that it wasn't on there is I went off of and I even missed including the anal cancer screening for men. I was more so focused on persons living with HIV for that. So I'll make sure I kind of update for the anoscopy, adding it to it. Mm-hmm.
Hello. Hello. I'd like to ask, is there any guidelines for physicians who prescribe Viagra to then check for STDs within 10 years? Is there any? It's just whatever.
Well, one of the things that we had been working on, I will say that unfortunately, I don't know what's going to happen with it now that we've kind of had a change in administration. But we have been working on increasing the age limit, I will say, for when a person should be tested for HIV. Currently, it says to be tested at least one time within their lifetime up to the age of 65. So one, increasing the age, but also then thinking about frequency as well for testing, and more so being focused on behavior and less on age.
Well, my question really is, there's no STD. My husband did not receive an STD check after being given Viagra until he had no immune system with tertiary syphilis. Now, I was supposed to get it, and then they...
I agree with you, Mary. I agree that they should be screening. Unfortunately, we know some are, some are not. Sorry that happened to your husband.
Are you allowed to refuse something from it? Like before surgery, the doctors are still requesting urine samples to see if I'm pregnant. There ain't no way in hell that's happening. So my question is, when I've tried to refuse it, they refuse surgery for me. And I feel that they're doing it as a cash grab, and it's just annoying to me. So at what point can you advocate and say no, and the doctor's like, oh, then you don't get this?
Well, I mean, when it comes to a surgery, they want to make sure. I understand that you're saying no, especially with the pregnancy one. But they want to make sure that all of the screenings, are done. Even if it's something to do with your chest, the chest X-ray is done. If it's going to be a really complex surgery, that they do an EKG. So they also have the right to refuse if they feel like those tests are not being done, because there is liability for them as well if they don't have all of that information to protect themselves in the case of an adverse event. So, and I'll also tell you, a urine pregnancy test is pretty cheap as far as like reimbursement for a pregnancy test. So if they want to grab your cash, it's probably not going to be with the urine pregnancy test. Thank you for the question.
Tamora, I want you to add to your list of advocacy steps is to be able to say no. Doesn't work. Difficult. Probably including myself, in a circumstance where to learn to say.
In addition to saying no, it doesn't work, to be able to say, I would like a second opinion. Because to me, that's another way for you to say no without maybe having to say, no, it doesn't work for me. I prefer a second opinion before I move forward. If you don't feel that you have the courage to say no. And I also recognize that sometimes it's generational with providers as well, where there's more of this paternalistic approach with a provider, and so kind of getting out of that into, as we started this conversation with, that it being the two of you on a team together, not them being, the person who's dictating to you.
The thing is about STI testing. I know that there were guidelines. That's why actually conversation with a practitioner about sexual practice. It's really indeed.
No, I absolutely agree with you. I do think that there is some accountability that providers should also have. So I don't want to also absolve providers that, I think Mary has, in my opinion, had a great point about if we're prescribing Viagra, we know that someone is having sex. So if we as providers know that someone is having sex, then we should also be recommending testing regularly. While on the other hand, recognizing unfortunately some providers are not thinking about it in that way and thinking maybe that risk is low. That is also the challenge, that they may be thinking that risk is low. And so also having that person say to their provider, I'd like to be tested, to make sure that the testing happens.
Regarding family history, how many degrees of separation should we worry about? Grandparents, great grandparents?
I missed the question. Could you say it one more time?
When you're taking my health history and talking about my family, how many degrees out should I be worried about? My mother, my father, my family.
So it's usually primary. Like usually it's your siblings, your parents. Also would go up at least to grandparents as well. So at least to that second level.
How many x-rays are too many x-rays for a certain part of your body? She mentioned her husband's immune system was affected. And actually at this moment, I'm referring to this part of it. Too many x-rays and then it's 4 months, 6 months later, they're not accepted at the next, your next step. Those are fresh x-rays 6 months ago, so why were they not accepted? I'm just saying,
I understand your question. I will say that x-rays have pretty low amount of radiation. I mean, I recognize radiation is radiation, right? But x-rays, pretty low amount of radiation. I would ask your provider why another x-ray is needed, because I think it could be specific to your, your condition. So I would ask the provider why, and is there a way to minimize the amount of x-rays that are needed and still get the best possible care?
Well, I tried to trust, and I'm just saying, I did what you said, ask them, and then when they insist on more, it to me it's overkill, and I am trying to save the insurance a little bit of money because to me it is invasive somewhat. I know you're saying low radiation, but if it's repeated, and if you have a family, I kept stressing, I have a family history of cancer. Can we talk about this? So anyway,
I mean, I also think that if you're saying the same thing multiple times and it's not being heard, maybe that's an opportunity to think about a different provider if you feel that you're still being exposed to risks that you're uncomfortable with. I think it kind of speaks to what we've been talking about.
We don't.
I'm sorry. Okay, all right. Go ahead, Ron.
A couple of slides ago, there was one of the points you said was access to medical information and data for providers. My question is, if somebody is attending a medical facility that is a nonprofit and they go out of business or close down, what the legal? How can you get records for something that's no longer exists?
That's a rough one. I mean, I don't know. I mean, it kind of is the same as if a place went up in flames. Like we just would not have a way.
I guess my question is, do these organizations have to answer to somebody? I mean, can you call?
So, Ron, I think that's a really good question for our last presenters from Inland County Legal.
Okay.
Because I think they could probably answer. We have two
Thank
attorneys
you.
speaking.
Thank you.
Thank you. All right. Let's see. I'm almost done. And thank you. Thank you all. I also want to encourage you all, if you can, to join my mailing list. I have a really big announcement coming soon. I'm not going to share it currently, but big announcement coming soon. And if you join my mailing list, you'll be the first to get it. Thank you all.
Okay. So, without further ado, I'd like to introduce Dr. Tamara Porter, who is the founder of My Health, My Advocate in Palm Desert. Dr. Porter brings over 30 years of experience in nursing, specializing in assisting older adults to navigate the healthcare system and coordinating care. She holds a Doctor of Nursing Practice, DNP, from Duke University and a Master of Legal Studies, MLS, in Health Policy and Law. Dr. Porter is a certified case manager. She's contributed to articles and publications such as Women's World and Self, and has been published in the Journal of Geriatological Nursing. You did that on purpose, right? So I would like to introduce my new friend and this amazing presenter, Deborah Porter.
Thank you. Thank you, Stephen. And Dr. Moore, thank you I love your proactive approach with, first of all, taking charge of our healthcare, because that's where it starts. Self-advocacy, we have to start with ourselves. And doing all those screenings are huge to prepare yourself for aging. And so we're all there. The sooner we can start, the better, as I tell my children. So I thank you. I appreciate your approach with that. First of all, I want to preface my presentation with a couple of things. In my experience, advocacy doesn't mean I'm an adversary. So when I'm with a client of mine at an appointment or my own family, I'm not there to fight. I'm there to collaborate with my physician, the other nurses, if I'm in the hospital. I can be very firm. I have a soft voice, but my husband, my family knows I can get louder if I have to, but I can get my point across without raising my voice. And I think that's really important when we have to speak up for ourselves or someone else that we're advocating for. Along those lines, I want to preface as well that I have a lot of great colleagues in healthcare, physicians, nurses, and as Dr. Moore indicated, they took a hit in COVID. I have colleagues that committed suicide, as he mentioned, that I worked alongside. One here in Palm Springs who was a wonderful man. I get a little choked up when I think about what a great physician and surgeon he was, who was willing to step up in peer review when we were looking at things that maybe weren't right or could have been done better. And he never failed to advocate for his colleagues and for patients alike. So COVID was hard on our physicians and nurses. And I don't want to lose sight of that. But again, we can't hide behind what happened in COVID when it comes to our own healthcare. So that being said, I want to share, we're operating or we're working within or we're receiving our healthcare in a system that's very complex. And we've heard that for years. I've heard that ever since I was a nurse. It's complex. When I was a case manager in a hospital, we need someone to help us navigate through that system. But still, to this day, we all recognize that the complexities are getting worse. So there's an article just here in February from the American College of Healthcare Executives. One national survey found that nearly 2/3 of Americans believe that the United States healthcare system is intentionally designed to be confusing. A national survey in June of 2024 found that only 40% of Americans have a favorable view of the nation's healthcare system. It continues. The Wall Street Journal had an article February of this year. People are increasingly wary of a healthcare system that is supposed to make them feel better, but instead leaves them stressed and frustrated. Some people are so overwhelmed by dealing with doctors. I'm sorry, Dr. Moore. They're so overwhelmed, and I see this time and time again. So some people are so overwhelmed with dealing with their doctors that they pay professional advocates like myself to coordinate their care. While this is beneficial for the people that can afford to pay for my services, it creates a gap between who can get that help and support and those that cannot. And I recognize that. And I value organizations such as Mr. Bass that I met today that are looking to expand these type of services for people that cannot afford a personal advocate. And I'll point you to a resource later in my presentation that can help with that. So the purpose of my presentation today is to make sure that if you cannot afford to have your own advocate, to be able to advocate for yourself. Let's see which direction we're going here. Come on, there we go. So my point today then is to help you identify why and when you need an advocate. And based on everything that you've been sharing, I think many of you recognize when you need to have an advocate because maybe your appointments or your hospital stays aren't going as well as they should. I want you to be able to identify the different transitions of care when that advocacy is so important because those are the times that errors can happen. And I want you to be able to advocate for yourself during those times. I want to give you some important tips for navigating through that time and some tools that are included in your binder that I create a binder like this for all of my clients. What a gift that Stephen has done for all of you participants, because you're going to leave here today with the start of something that people who pay me, they get, and you're going to leave with that and a lot of great information to add to it. I will say that I think he gave you 2 copies of some of the documents that I put together. Maybe try to make some of your own copies when you get home so you can use those for the future, especially because medication lists, those things change often depending upon your diagnosis. So make sure you have extra copies. Don't use up all your copies so that you have those for future. And then we'll talk, of course, about end of life. So I have a prayer. I didn't write this, but I wish this for all of the people that I have the opportunity to share information with, for all of my clients. And that is, before you must accept the things you cannot change, seize the time, and I'm going to add now, to prepare for what's ahead and to change the things that you can. This is an opportunity for you to do some of these wellness screenings that Dr. Moore mentioned. This is an opportunity for you to start building this medical binder, as I'll call it, to prepare yourself for your future visits and hopefully not, but a potential hospital stay or surgery or a condition that may involve a lot more treatment than you really wanted. So why do we need a health advocate? There are personnel shortages related to COVID. And because of that, we're in a real crisis with nursing and primary care physicians across the country. You may know it's in the Valley, it's hard to find a primary care physician that's taking appointments. Nursing, we have travel nurses that are in both hospitals, Desert Regional and Eisenhower, that I'm in frequently. It's across the country a problem. There's insurance issues. I've also worked in patient financial services, so I get asked about medical bill review. So those are also times when you need a health advocate. Understanding your health conditions, your treatment options, being discharged too soon from the hospital because they need to roll those beds over because the emergency rooms, as you may have experienced in the Valley, you could wait 5 to 7 hours, and I was one of those patients. I've seen doctors and visits recommend to their patients, well, if you're going to go to the emergency room, I went there with my son, and so even the doctors and their families are having to wait. It's not just, those of us that are trying to get care or there for an emergency. It's also our doctors and nurses there. Not having a plan for caregivers at home is huge as we're aging. And that's also a time to have an advocate, and I'll share with you a little bit more about why. Trying to stay out of the emergency room, again, is huge. And then all those care transitions that I talked to you about that are important. In addition to all of that, health literacy is a common problem. just out of curiosity, what do you think is the percentage of adults in the United States that have proficient health literacy? Does anybody want to take a guess that how much? That's pretty close. 10% is pretty close. So it's 12%. So what does that mean to be health literate? Health literate is more than just being able to read read health information, read an article, maybe know a little bit about diabetes or heart failure if that's your diagnosis. But it's also being able to locate and find providers and services. It's about communicating, knowing how to communicate with your providers. That is part of health literacy. Being able to manage when you have a chronic condition, knowing what all of those steps are, knowing what all of your treatments and your medications are. That's part of health literacy. Understanding basic math concepts, health math concepts like your blood sugar numbers, what's a normal blood sugar, what's a normal blood pressure, your insurance copays and deductibles, that's part of health literacy. Anyone can have low health literacy. You can be a trial attorney, one of the most renowned attorneys in the country, and be health illiterate if you don't have an understanding of your health, your chronic condition, the numbers, the lab work, all of those things that go along with that. So I'm sharing this this continuum model. This is for the profession of case management. And it's an ongoing process. You see it's circular, and it's across the entire health system. It's when I'm a case manager as well as a nurse, I'm following a patient across their entire lifespan. And you can see that advocacy is a part of that. It's the complete journey with a patient. I apply this model as I guide patients through the complex healthcare system. Advocacy is a strong hallmark of nursing and case management. So let's start with your journey. This is an example of the multiple settings and transitions of care that go along with the healthcare experience. It can start in your physician's office. Maybe you're just getting established with a primary care physician. Maybe it actually starts with a hospital stay for you. You have an unanticipated event, you fall at home, and that's where you're starting. That fall at home may lead you to rehab because maybe you don't have anyone at home to take care of you, and you need to go in and get some intensive therapy before you go back home. Care at home, going from hospital or rehab to home, is also a transition of care. And then, of course, end of life. So self-advocacy, if we look at the definition of that, and this is from a Journal of Clinical Nursing, more related to oncology, but it fits no matter what your diagnosis is. Self-advocacy focuses on equipping patients with the skills necessary to overcome challenges they meet along their journeys, with the goal of optimizing their care so that it fundamentally addresses their needs, values, and priorities. Patients who can self-advocate ensure that their individual needs are recognized and integrated into the care they receive. This respects their autonomy and facilitates collaborative partnerships with their care teams to promptly be able to then respond to whatever your ongoing needs are. So that's where health advocacy starts. But let's break it down into some really usable, as we click through all those different stages, let's start talking about where this begins, especially in the physician's office. So as Dr. Moore talked about, beware of credible sites for information. So when you're looking to get smart fast, which is really important, especially if you're dealing with a new diagnosis, you have a new blood test with something that you're not anticipating, like your blood sugar being now 220 and it's normally been 80 or 90. Well, what am I going to do about that? Make sure that you're using those credible websites, as Dr. Moore suggested. Know the vocabulary of your disease. So heart failure, you may hear your doctor say, well, when you're dealing with CHF, and I'm in an appointment with a patient and they're like, what are you talking about? What's that? What's CHF? Or, what's an A1C? He says I need a blood test. What's an A1C? So I feel like I'm there as an interpreter many times, but this is where you can do some of your own homework and get ready for those visits. And I'll give you a tool to do that. The binder is huge. So get smart fast. Start doing the research about your condition, whatever it currently may be. And the binder that you're leaving with today is a great start for that. So I suggest there's a plastic sleeve. I keep this for my clients. Stephen was great about putting that as a resource. You're going to pick up business cards everywhere you go, right? At all of these different appointments, especially if you're going to specialists. So there's a sleeve in there for those because you'll often be in your primary care doctor and I saw a nephrologist, but it's outside of the health system. Well, who was that? You can immediately flip to that and have that information or contact information for your primary doctor. An updated med list. So as your medications change and you have a blank med list in your binder that you can start using, keep that up to date so that when you go for your appointments, they're going to ask you every time, which I know is frustrating. It's like, you always ask me that, but something could have changed. You could have been to a specialist who now's prescribed something that might interact with one of your regular medications. So keep that medication list updated because you're going to have to give that information when you go to the doctor. Keep a chronology of your illness. So also in your binder today is a place for you to go ahead and start logging. It's really important to log like the years. If you can remember, you're going to be asked that. What year did you have your gallbladder taken out? When did you have a hysterectomy if you had one? You're keeping all of that, especially when you're going to a new doctor, is helpful because you're going to get asked those questions. Thank you. I'm getting ahead of myself. Okay. And don't hesitate to call me out. This is interactive. And if you have questions as well. So, and your medical history, again, we were just talking about that. And I like to, I say keep it in order, to have the years available if so. All right, stand your ground nicely. I said advocacy is not being an adversary, but if you're in your appointment, start making friends with the people at the desk. They're going to be more inclined to get that appointment if what's the old saying? You get more with honey than vinegar. It makes a difference. They remember that because believe me, since COVID, there are a number of people that will be at that desk and they're demanding. And it just, people get on the defensive these days, especially after COVID. There's a lot of people that approach the desk that feel very entitled. We see that in the desert, right? So we see that in the grocery store in the desert. I just stand back. But, but be nice as well as you can. And sometimes it's just taking a breath. You may have come and just received some bad news, or you're there to confront and deal with that bad news. So you're coming from a tough spot. They may have just watched someone walk out crying because they had a cancer diagnosis. So let's just be kind and understanding with each other. It does help. But don't be rushed out. And Dr. Moore also spoke to this a little bit as well. So if you're in your appointment, and we're going to go through how to navigate that appointment quickly, don't leave until you can say in your own words what your understanding is of what the doctor just shared with you about what the test results, what the doctor wants you to do when you leave, what's the next step after this appointment. And I'll give you some tips on how to do that. So we've all been, including myself, been in appointments where you can tell that he or she is ready to, I got to go to the next patient. or they come rushing in and they've got to see so many people that day. I get that. We all are busy. But you could just say, before I leave or before you leave, can we just go over, I want to clarify what you said. I heard you say that XYZ, whatever it is, because you may have heard it incorrectly. And that's a great time for a great time for the doctor to make sure that they gave you the information that they wanted you to receive and that you understand it. It's a great opportunity for you both to get on the same page. In healthcare, we call that teach back. So anyway, there's a tip there. Bring a note taker too. Bring someone with you. An advocate is part of their responsibility. Bring your neighbor, your friend, someone that you feel comfortable with, maybe hearing some sensitive medical information. My parents live in Illinois, so they can't have me there. So I tell them, put me on speakerphone. And so at the beginning of the visit, and they don't do it secretively and under the desk and hide their phone, I say, Mom, tell Dr. So-and-so that I'm here. And so I say, hello. So you have your advocate on the phone if you can't have him with you. It's because we all don't have that available to us, like my parents. So, okay, always follow up. So don't ever assume that when they say, I'm going to make that referral to imaging for you to get an MRI. If you haven't heard from them I'm going to give them 36 hours. No. Yeah. Okay. 36 hours. I'd call. Just call and say, my doctor ordered an MRI, because that list, especially in the desert during season, will be a mile long. So don't hesitate to call and follow up on getting that scheduled. If your test result, if they say, we'll call you with your test results, may not happen. So follow up. Keep a list of all those things from the follow up. You get that printed visit summary when you go to doctor's appointments. That's also a place where you can write down the things that you need to follow up on, and then don't lose sight of that. If the prescription's being called in, especially if you're being discharged from the hospital on a Friday afternoon and there's no 24-hour pharmacy and you're going to need that medication, if you're waiting to be discharged because the nurse hasn't come to your room yet, send a family member, a neighbor, someone where you get your medications. If those prescriptions have already been sent electronically, you can verify that with your nurse. Have them go and pick up your medications if it's going to be cutting it close to when the pharmacy is going to close. I've seen some great doctors that have actually gone on Saturday and went to try and help them out, but that doesn't happen very often. So that's another way to advocate for yourself. And then just make sure that the orders are sent. So in your binder, I believe, Stephen, are the little booklets, the handbooks? Okay. All right. So on the left side of your binder, you have this handbook. It's called a handbook because it's a way for you to use your full hand to prepare for your medical appointments. So I partnered with the University of Arkansas. They have a Center for Health Literacy. So I thought this was a great evidence-based tool because they've seen how it can work for doctor's appointments. So let's go through this together. So everybody hold up one finger. Okay, one. So one means remember to take all the things that you might need for your appointment. And I'm going just right through the booklet, and you'll have this too. And again, don't write on this with your very first appointment. You'll want to make sure you can use this again. If you do, use a pencil because you'll want to use this again and again until it becomes ingrained. So number one is remember, take all those things you're going to need. Your insurance card, your ID, your driver's license, your medication list, your binder. If you have everything in your binder, you're good to go with most of the things that you're going to need. A calendar, your calendar, or however you schedule your appointments. I use my cell phone, but maybe you have a little paper calendar, and you can actually clip those calendars right into your binder. Your bag of medications, all of the things that are going to be important for your doctor's visit. All right, that's number one. So number two, everybody, 2 fingers, peace. Yeah. Okay. So you need to practice and be prepared with a 2-minute history of no more than 2 minutes. And honestly, if you can cut it to 60 to 90 seconds so that you get your doctor's full attention, because again, they're on the move, this will get you more of what you need if you prepare this in advance. So here's a practice this. So here's something that I wrote out. Let's just say I'm diabetic and I'm going for my doctor's appointment. So, doctor, I have, as you know, type 2 diabetes, and I've been taking pills for it for about a year. My blood sugar readings have been going up lately, especially when I had a bad cold last week. In the morning when I get up, my blood sugar has been around 205. Then when I check it 2 hours later after eating, it's been around 130. Also, I take medicine for high blood pressure. It had been better since I started medicine about 6 months ago, but for the past 2 weeks, it's been higher. It's been running around 145/90. I'm here today because I'm worried about my blood sugar. It keeps going high and low, and my blood pressure just seems to be going up. I don't want to take more meds, but I know bad things can happen if I don't get my blood sugar and my blood pressure down. I hope you can help me. So notice that I'm using numbers in communicating with the doctor. The doctor needs those numbers, those facts, to be able to understand what's going on with you at home. So be very specific about your concerns. Try not to talk in generalities. Be very specific and prepare this in advance. When I have a 93-year-old that I take to her appointments, and boy, does she take this to heart. She has little bullet points. And she doesn't let the doctor get in too big of a hurry, because if they're ready to head out the door, she's like, oh, no, I've got 2 more things on my list here. And they're great about taking the time. So to come prepared, because they appreciate that. That's going to make their job easier if you're just pulling things. Let's see, because I'm bad about forgetting too. You know, I'll get into an appointment if I'm not prepared, and this has happened to me. I think, now there was one other thing I wanted to tell you. What was it? And they're like, okay, I got to go. So be prepared. So a 2-minute history. So that's 2. Number 3. Yep, we're using our hands. So we've done 1, 2, now 3. How will you repeat instructions information in your own words? So saying it back in our own words, what the doctor has just shared with us. That helps them know and us know that we're on the same page. And it's that teach back that I talked about. So you can say, here's some options, and here it gives you some options. So when they give you all of the information, you say, so here's how I understand you. Here's what I'm hearing. Or, so when I go home, I'm going to do X, Y, Z that you just talked to me about. Or it could be a long visit and you have to summarize and say, okay, you just gave me a lot of information. Let me make sure I got it all. And then you go down the list, but use your own words so that they know you've heard them correctly and that you're going to leave and go do the what they're asking you to do for your health. Okay, number 4 is forms. The binder helps your past medical history, your list of doctors that you currently see or specialists, their address and phone number, and any other health information that you might need. Those forms are super important. Now, with 5, which is the last one, I'm going to say, take your meds, and then I'm going to hold my hand this way and say, take your meds, because you want to take your meds with you, the medication list, but take them as prescribed. So many ER visits result from older adults not taking their medications as they're prescribed. Well, they told me to take this twice a day, but I think I'll start with a quarter tablet. You know, that doesn't work for what there's a reason that they're prescribing to you the way. And if you don't understand that reason, or maybe you're having side effects, that's part of that conversation to have with your doctor, but don't take matters into your own hands with your medication, because that gets a lot of people in trouble. at the back of your little booklet, there's also another place to list medications if you want to just keep it concise and you don't have a long list of medications. So that is preparing for a doctor's visit. Now, let's go on to if you're admitted to the hospital or rehab, unless the clicker just died. There we go. Okay. So before you're admitted to the hospital, if possible, or when you go, identify who your advocate is going to be. Who's going to be at the bedside or who's going to be coming in of a morning when you're in the hospital or rehab. Prior to surgery, this is something that you need to do if you're going to have, if you're in the hospital to have a hip replacement or a knee replacement. Know this before you get admitted. The case manager is going to come to your room, and this is also in the case of, let's say you've been in the hospital for 4 or 5 days and you're just really weak and deconditioned and you need some therapy or rehab before you go home. They're going to come to your room and they're going to know what are your top 3 choices of rehab to be where you're going to be discharged to. Number 1, case managers are required by Medicare and by law to give you a choice. They can't tell you that for any reason, well, this is the one I think you should go to. People that I'm their advocate, of course, I'm going to say, well, I've been there. I've seen this X, Y, and Z. But a website that you can go to check that is, it's on this next slide. I'll switch to real fast. It's called, it's Medicare.gov, and it's Care Compare. And that's the website, and you'll have this in your binder. But you can put in your location. So if I put in Palm Desert and just click search, and I'm on the nursing home, including rehab services, it will list all of the rehabs in your area. If you put in Palm Springs, it'll list all of the rehabs in this area, and they have a star rating. So 5 stars is meaning they've met all of the quality measures, all of the, there's also cost of care, et cetera, but you're looking for a 5-star facility. Does that mean they're perfect? No. I don't know that we have any healthcare facility, including Johns Hopkins, that's perfect, but they have met all of their quality measures. But if you can, if it's a planned hospitalization and you know you're going to go to rehab and you know what you've done your research, also go visit them. Because I've had a 4-star facility that one of my clients went to. It wasn't real aesthetic. You know, the paint was a mess. The furniture it looked like it needed to be replaced about 10 years ago. So make sure you're going to feel comfortable going there. So visit it in advance if you can. Or if you're in the hospital and you've got an advocate and you know you're going to need rehab and you didn't anticipate it, have them go take a look and just, you know, they'll give you a quick tour. You just go to these facilities and just say, I'm thinking that I may need to come for rehab. Could I take a quick tour of the area where I would stay or where my loved one or friend would stay? Make sure that, so I'm going to go back to navigating for hospital admissions. Very slow. There we go. Oh, too far. Back again. There it is. Okay, so your copy of your discharge paperwork and medication list. So make sure that it's yours, because I've left the hospital and in the parking lot and realized they gave them the wrong patient's list of information. So make sure it's yours. And if you're anticipating discharge from whether it's rehab or the hospital, know when, ask about when I might be going home, because then you can start preparing for whoever's going to be at home. If you're going to have caregivers at home, if you're in rehab and you may need more caregivers at home, you can start planning. So they can give you an estimated discharge date. And in fact, if you have Medicare, they will start that process very soon after you're admitted because they know that Medicare is only going to pay for so many days of hospital or rehab, depending on how much progress you're making. You're going to also want to anticipate what equipment that you might need at home. So the hospital case manager or the rehab social worker can help identify. They'll start asking you, what do you already have at home? Do you have a wheelchair? Do you have a walker? Do you have a raised toilet seat? The things that'll make it easier for you at home. Your home care may have insurance coverage and maybe not. And then just as you transition from rehab, they may make a referral to outpatient physical therapy. So there'll be additional services. All right. So that's I'm just going to stop for a second for hospital rehab. Are there any questions about when you're in the hospital or rehab and you're getting ready to transition to home? If not, we'll move on. It goes at its own speed. Maybe the battery's dead. Okay, one more. One more. Yep. Okay, so advocacy for care at home. Again, having your advocate. Home health can also, on that same website of Care Compare, you can also, as you're asked to choose which home health company you might want when you're being discharged, you can also search for the star ratings for home health and hospice as well. So that is also listed there. I want to talk about private caregivers. If you're going to need private caregivers at home when you're recovering from a surgery or just for long term, maybe you or a loved one are going to need extra help at home moving forward. Just remember that there's private caregivers, individuals, and then there's agencies and companies. Something that's really important is making sure that you choose someone who is licensed by the state, that is bonded with insurance, and that has credible work experience, because they're going to be in your home, and if they're not licensed and bonded and they get injured in your home, they could sue you and you could be responsible. They could also, there's some wonderful people that are unlicensed providing caregiving, but all it takes is one bad thing to happen and suddenly they're suing you for back wages because you're their employer. You're paying for their care, even if you've been paying cash. There's a story in the desert about a housekeeper who became a private caregiver for years, but then suddenly things turn. There's personality conflicts, whatever, and they went back and then sued for back wages from the moment that they came in to be your employee. So when you have someone who's licensed and bonded and works for a company or an agency, you have a lot more protection than if you're hiring someone that's just an individual. But I'm also going to show you a resource for that too.
Tammy, can I ask a question?
Yeah.
A lot of people who are on Medicaid in the desert are using in-home health services, IHHS. How does that, what is the recourse there? Who takes responsibility if something happens in your home? Is it the state of California, or is it the homeowner, the person?
So that's a good question. IHSS has caregivers, and that would be a state responsibility. And if you're having problems with those caregivers, so my mother had one, and she was borrowing money from my mom in Illinois, and she worked for the state. And so that's number one, big. And my mom's like, "Oh, it's okay. She only needed $20 to." I'm like, "Mom, you're getting state assistance because you need that, and you can't be giving it away." My mom has a big heart, and so so that would be then reported to the state agency. So there's a area on agency for aging and you would report any type of, and they would be responsible then. So I would direct you to the state for sure for IHSS workers if there's any issues there. If you happen to have long-term care insurance, there's a whole process to follow for, does anybody in here have long-term care insurance? So there are a few. Okay, just remember a couple of things about that with caregivers. Again, long-term care insurance generally wants caregivers that are licensed, certified, bonded. You can have private individual caregivers. You'd have to check your individual policy. But if you haven't had to use that policy yet, now is the time to go look at, ask for it. You may not even have a copy of your policy. Some people have paid into it for years and never really paid attention to it. But now is the time to get your policy out and look at the definition of what would it take to have an approved claim. So generally that means you're having trouble with bathing, cooking, getting to appointments, so know what the requirements are for an approved claim. And then there's that waiting period, or it's an elimination period is what it's called. And that's usually 90 days. And if you don't remember this when you purchase that policy, you have to pay for those first 90 days out of pocket. It's like your deductible before your benefits kick in. So remember, those first 90 days are your responsibility and you don't get that back. But after the 90 days, then you start submitting invoices from your caregivers and you can get that reimbursed. But I advise you again, prepare now, start looking at your policy before you have to use it. We talked about discharge paperwork, medication list. The thing about medication lists, when you're discharged from the hospital or rehab, oftentimes your medicines may have changed. So you may think you can go home and just restart taking your same medications, but you really need to look at those and make sure nothing has changed that you need to update on your written list and in your medicine cabinet. And don't, again, change your medication regimen unless you talk to your doctor first, including vitamins and supplements, because sometimes those can interact with your other medicine. And we talked about equipment for home. Medicare, there are some things that they cover, Medicare or Medi-Cal, and some things they don't. And so don't anticipate that things like shower chairs are going to be covered. Some things are out of pocket, and so you just want to know what your benefits are. There we go. Okay. So through all of these steps, physicians' offices, hospital, rehab, all of these are transitions of care when you go from one to the other or back again. Those are all opportunities for something to happen that could have an impact on your health. So I just want to go over, again, medication management. We talked about your current list. Use a system to take your medications. I know that you can, I know when to take that pill. I've always taken that pill. But then as things get complicated with your medication regimen, especially if you've been in the hospital or rehab, you want to set yourself up with a reminder. I make my 60-year-old husband use, because I'm always asking him, did you take your blood pressure medicine? I think I did. I'm like, well, if you use that little pill box that I got for you, you would know if you took it or not. So use some type of a system to remind yourself. Some people set an alarm on their phone. Your physician follow-up, your follow-up appointments. Schedule them, be prepared for them, and then go to your appointments. Sometimes people avoid their appointments because they're afraid of what they're going to hear. And you have to face it so that you can deal with it. Knowledge is power. And so go to those appointments for sure. Following up on your personal health record, are you guys using your portals like MyChart? Or that is what I have found, that's the quickest way to get a response from the doctors or their staff. If you call and you're getting frustrated, well, I called the office, or I've left a message for the medical assistant, or I've left a message from the nurse, you're going to get a much quicker response if you use the portals. So if you haven't signed up for your portal, I really encourage you to do that. and you can share your portal with whomever you choose. So all of my clients have shared their My Chart with me. So I have access to all of my clients' My Chart. So I can send messages on their behalf, and the doctors and nurse practitioners are great about getting back. You can do that with your own advocates. So it's called a sharing hub. If you go into your portal, look for that, and you can share with whomever you designate as your advocate. Be sure to have your allergies on your medication list. That's a good spot so that when they ask for an update of your medications, you can actually pull your medicine list out of your binder. And the medical assistants love it when they're checking you in for your visit. They can just take a copy of that, and that makes their life easy. But just make sure you keep your allergies on there too. And then the red flags of your condition. So if you have heart failure, do you know what you're supposed to do? What are the red flags? Are you weighing yourself every day? Have you noticed that your ankles are swelling? Your blood sugar, know what your parameters are. If your doctor wants your blood sugar below a certain number, and if it goes above that, what am I supposed to do? So know your condition, know what the red flags are and what the steps are that you're supposed to take. All right, so we're getting down to the end of my presentation, and we're going to start talking about end of life, which I know you're going to have a presentation about this. If I'm going through the whole transition of care and your whole journey, the end of our life is also part of that journey. And I want to make sure that I point out and talk about the difference between palliative care and hospice, because there's a lot of misconceptions, even in the medical community, about palliative care versus hospice. So if you look at this this diagram here, and you look at the green, when you get a diagnosis, let's just say it's heart failure, since I've mentioned that so many times. As you're going throughout your life, it's curative care. Maybe you're getting a little short of breath. Maybe you're having, swelling in your ankles. Maybe you've got a cough and you've got sputum production. As you're going through your life with heart failure, you're in the green zone. Your doctor is treating that. Okay. But then as your shortness of breath starts to increase, it starts to get worse. And so your doctor is, at the same time you're getting treatment for that, he or she is addressing those symptoms, and that's palliative. My mother-in-law was at MD Anderson with oral cancer. She was getting curative care because she was there for radiation, chemotherapy. She wanted to get well, but we also went to the palliative care department because as she was getting radiation, she had burns to her throat. So she was getting palliative care along with curative care. So if a doctor or a nurse practitioner starts talking to you about palliative care, that doesn't mean hospice. Now, there are some hospice companies that offer palliative care along with hospice care, and that's because they're treating those symptoms that you may be experiencing with whatever your condition is. Palliative is meant to treat those symptoms and resolve or keep you comfortable through those symptoms. Maybe they can't change them, but they can help you deal with those symptoms. Now, where hospice comes in is if you've gone through curative care, palliative care for the symptoms, but that heart failure is now to the point where it's not going to get any better. And the doctor says you're at the end, this is end stage heart failure, and we don't see this improving. And you may have 6 months or less, an actual prognosis of 6 months or less. I think that hospice would benefit you. I encourage you, no matter what your diagnosis is, if your provider starts talking to you about hospice, that doesn't mean you're going to die today. It doesn't mean you're going to die tomorrow. My uncle was diagnosed with lung cancer, and the oncologist said, "You've got about 6 months." And he started laughing. And she's like, "Why are you laughing?" He said, "You could leave here today and get hit by a car and die before me." And he's right. You can live in hospice. Every day is a choice to live. And so just because you have that prognosis and you're receiving hospice care, that doesn't mean you're going to. So if hospice is ever a conversation that you have in the future, I just want you to remember this diagram. Live in the green and the purple, the pale purple. And then when it gets to the point of, there's not going to be anything we can do any further. It's hospice, time for hospice. It's just an extra support system. Hospice is great. They have they get all the equipment. It's paid for by Medicare or Medi-Cal or Medicaid, and you've got nurses and some caregivers to support you. So I just don't want you to be afraid of that. And along those lines, I didn't mention this earlier, but that wonderful Nurse Serenity Prayer, it was written by this Katie Butler. This is an amazing book. I've got mine flagged where I'm at in this stage of life, but it's called The Art of Dying Well, a practical guide to a good end of life. And it's not about dying. You find the stage of life you're in if you're in your 50s, your 60s, your 70s. And it's really practical information. She's not a nurse, she's a non-clinical person. And it's a great tool to just start preparing you for what you want your end of life to look like. So we're getting close here. This is a resource. I mentioned earlier that if you can't afford a personal advocate, not everyone can. This is a new resource called solace.health. This is in your binder. I started with them when they were a startup. So the developer his name is Jeremy Gurewitz. His mom was an interventional radiologist in the Bay Area and had some really bad experiences with the healthcare system, and she passed away. So he was dedicated and determined that people should have an advocate in dealing with the healthcare system. So it started out as a paid service, but he is now contracted with Medicare, where Medicare will pay for an advocate. So if you have Medicare, and they will I would encourage you, whether you have Medicare or Medi-Cal, if you have a need for an advocate, this is a great resource because I've never heard that they've turned anyone down. You get your whole, whatever your issue may be, they'll assess the whole thing and they'll appoint the right person. If it's a medical bill issue, if it's a provider issue, if you're looking for care, this is a really great resource. So I highly recommend that as something for you to find an advocate, no matter where you're at. And this can be used across the country. So this is national. Solace.health. Health. HELTH. I love when things like this happen because it's like it causes me to slow down. You get in a hurry and you're like, okay, this just is an opportunity for me to take a breath. Okay. So the last slide, and then I'll take questions that you might have. So remember, you're the captain of your own ship. You've heard that before. Use this education that you are receiving today from Dr. Moore, myself, and the legal team that'll come after me. This is amazing information that a lot of people really need. And so I applaud you for being here and taking things into your own hands for sure. Actively advocate for yourself always. Know when you need help, so bring someone with you. And I say bring someone with you no matter what. Even myself, after the couple times lately that I've gone by myself, I tell my husband, I'm like, I wish you would have been with me, because he said, did you ask this? Didn't prepare. And sometimes I don't hear, he hears things that I miss. You might get some news that is maybe not what you're expecting, and you will get focused on just one thing that's said, and they can hear everything and remember for you. So it's really good to have someone with you. Know who will be your advocate when it can no longer be you, and start talking to them now. So something else in your binder is something called 5 Wishes. I have been using and promoting this document since, oh my goodness, probably 25 years. I love this document. So yes, it's an advanced directive where you can choose who you want to make decisions for you when you can't make them yourself. but it's really specific about end of life. So I've told my family, if I'm, heaven forbid, something happened and my mom's still alive and I have a diagnosis, my mom is a sobber. And I do not want, if I'm at the end of my life, I don't want my mom crying at my bedside. So I literally wrote in mine, no sobbers at my bedside, because you can be really specific. I mean, if I'm, laying there and I'm taking my last few breaths, the last thing I want is that. And I want pictures of my family there. You can be very specific. I would like a cool washcloth. You can look through the document and check mark what you want. But the big thing about whether you use just a plain state form for your advance directive or whether you use the 5 wishes or something like that, you have to share it with the people. Number one, the person that you're designating to be your decision maker, make sure they have a copy of it. Make sure that your physicians have a copy of it. And when you go to the hospital, they need a copy of it. So then as things happen through your journey, your healthcare journey, everyone knows what you want. So that if you don't want to be on a ventilator or feeding tubes, those things at the end of your life, everyone that needs that document has it. So that, I think, is all that I have. What questions can I answer?
My question is about advanced healthcare directives, or if people are in the hospital and they have a do not resuscitate order. My partner happens to work as a respiratory therapist in a hospital here in the Valley in critical care and most time in critical care and in emergency care. And I'll just go back. Yes, COVID. He's been in it for 30 some years and said he saw more people die during COVID than he had seen in the previous 30 years. So very stressful for the healthcare professionals. But he so often, and the doctors and other healthcare professionals experience families coming in knowing what the wishes are of the patient and ignoring them and threatening, and they're afraid to follow the advanced care directive because of concerns about malpractice insurance. So how is that navigated?
Well, and you'll have a legal team that's also going to talk about this later, but that's where you have to have that written document. So you can't, if you have a legal document that's been notarized, that's clear what the patient's directive, what their wishes were, and you have someone that has that document and said, my sister may fly in from Seattle and have a completely different opinion about what care my mom wanted. But I have the document that my mom signed that this is what she wanted and I'm the decision maker. And that there's no question. And that has come up in my family. And the legal team had to review the document and decide this is the person that will be the decision maker.
I just want to add to that in the hospital, we all have the ability to control who does come to our bedside. So if you share that with the hospital and say, I don't want my brother here or my sister's a nut job or whatever, they're going to try to change things. That's within your control. You don't have to have anybody and everybody visit you if you feel there's going to be a disruption.
Yeah, for sure. Definitely. Other questions?
I am an IHSS provider and power. And, I am his advocate, and I go to every point pretty much across the board. The physicians and providers, very dismissive. Doug has aphasia, he has a hard time communicating, and that's why I'm there. So they tend to just dismiss me, and that labors. How do you suggest dealing with that?
I've experienced that in my role. And so here's a couple things. So I've been with my client at their cardiologist, and my client's chair was over here. I'm sitting over here because I do believe that it's between the patient and the doctor, or the patient and the nurse practitioner, because they're there for the patient. They're not there for me. However, if that person has hired me because of multiple reasons, maybe they can't communicate, they're hard of hearing, they have me there for a reason. So this cardiologist had my client's back. So he turned his chair and turned his back to me and just faced the patient, which I get what he was trying to do, but I can't participate that way. So I just politely got up and I just, nice, I walked around him. I said, "Oh, I'm sorry. I need to be here for him because he's really hard of hearing and I want him to be able to hear what you're saying." So if you can approach it in a way that I'm here for him to be able to do what you want them to do, I want to support that. If you can relay it in a way like that, but be a little assertive. So I did, if I sat back behind him, he's sort of putting me in my place, but I stood up and I made it clear that I'm here for this person who will do what you want them to do if he can hear what you're saying, and I'm here to help with that. Do you see how I kind of navigated that?
Yes, and I try to do that, and it's like,
And sometimes it doesn't work.
yeah, I say, and he's 90% blind, so I'm gonna be helping. I'm gonna be present, helping communicate. Thank you. I just have one other comment.
Yeah.
About your 5 wishes. There's also something called "I'm Dead, Now What," and it's a book,
Oh, I haven't heard that.
and it's giving it to my family every
Where do you find that?
online.
Okay.
But it's a book that takes everything from care to your physical belongings, but it's a great thing to give to people and make sure.
I like it. Thank you for sharing that. Okay.
Yeah. I want to share with you a resource. Like Dr. Porter said, we have to plan ahead for care. We can't wait till we are in the hospital, right? And so when you go to the dining room, on the piano, there are brochures for a no-cost educational program called PALS, Planning Ahead for LGBTQ Seniors. It's very handy. And I propose, instead of going to a restaurant, go to assisted living for lunch, and then you'll know exactly what's going on before you need it.
That's a great suggestion. That is
Dr.
a
Porter,
great
thank you very
suggestion.
much.
Yes, yes. Okay, Stephen, are we need wrap it up?
Oh, I have a question.
Oh, I'm sorry.
No, don't worry, Dr. Porter. Thank you so much. I really enjoyed your presentation today. Okay. I love the little booklet. Do you have a recommended digital platform, like a website or an app? Because that would work better for me.
I do. It's great. I am so glad you asked me this. So I have a colleague who's a nurse. In Indiana, her husband's an ER physician, and they developed something called Primary Record. Check it out. It's primaryrecord.com, and it's an app that brings all of your portals, because if you have your doctor's office portal may be different from the hospital, or maybe you go to Loma Linda for specialists. It brings all of the portals together. There's a place that you can use to message. It even has AI, Chat GPT. Because it's consolidated all your portals, you can say, when did I have my last tetanus shot? And it searches all your medical records to get that information. Like, you can be using it in the doctor's office.
Okay.
It's
That's
so cool.
exactly what I need.
Yes, it's so cool. Check it out. It's called Primary Record, and I think it's primaryrecord.com.
And it
But they're
operates both
legit.
on a web and an app.
And the phone. Yeah. Yeah, it's awesome. I think it's .com. If anybody finds it real quick, yeah, it is. Well, it's web-based, and it's an app that you can download called Primary Record. And I say primaryrecord.com because you can go to the website and check out like what it's all about before you decide to download the app. Right, just Primary Record. Good, good, good. Okay. Thank you so much for having me. I really appreciate it. Thank you very much.
I apologize, but we only have the room to a certain amount of time, and I know that Dr. Porter also has to get to a patient. We are serving lunch back where you got breakfast and coffee and stuff. If any of you have any questions afterwards that haven't been answered, feel free to contact me directly. I can give you my business card, and you could send them to me, and I could forward them to Dr. Moore and Dr. Porter. When you go in there for lunch, keep in mind that we, as HARP, we are basically, we're a nonprofit. And in order for us to throw things like this, it takes money. And unfortunately, given the unstable sense of our government right now and grants, we're always kind of freaking out that the shoe's going to drop any moment now. So if you have it within you, and if you can, there is a kiosk when you go in for lunch. And if you could give a few dollars or a lot of dollars or whatever, it would be appreciated. It doesn't matter how much at all. There's a custom amount. If you want to give 50 cents or $1, that's fine. But everything, and that's how we could do these things. So please enjoy. ICLS provides assistance in areas such as consumer law, health law, and LGBTQ services. Today we have help me. Orozco, sorry. It's okay. Overseeing ICLS's LGBTQ plus services program. He brings over 5 years of experience working with the LGBTQ clients, ensuring they receive affirming and culturally competent legal services. And Mara Greenwald, you said I could pronounce that one. We're part of the same tribe. Focusing on obtaining and maintaining health benefits, Mara works to increase access to health services for clients, ensuring they receive the care they need. So please welcome Elle and Mara.
Good afternoon, folks. Happy Saturday. Thank you so much for sticking around. We will try to keep this as tight as possible. Just a gentle reiteration. I am Elle. My pronouns are they, them, staff attorney with Inland County's Legal Services. Before we continue and I talk about all the services that we can provide for free, assuming you are eligible, I'm going to let my colleague introduce herself.
This one work too? Yes, awesome. Hi everyone, I'm Mara Greenwald, staff attorney with the health team at Inland County's Legal Services, pronouns she, her. And like he said, anything related to healthcare, we do it.
Perfect. And I'm wondering if we can move on to the next slide. Is that something that I can use? Oh, perfect. Thank you. Okay. So we'll breeze through this. Before we go any further, we are obliged to share with you all a legal disclaimer, right? The information we're sharing today is for informational purposes. We are not establishing a formal attorney-client attorney-client relationship. There are formal steps that need to take place in order for us to establish that kind of relationship, which I will shortly talk about. I'm not going to do you the disservice of reading that. That is just a synopsis of what is on the slide for you all. With that, I can just share a few objectives that we have today. One, again, providing that high-level overview of the services that Inland County's Legal Services provides. General eligibility criteria. Then my colleague Mara will jump in, share about the process for filing complaints, health plan appeals, grievances, health privacy information. I'll step in at the end, talk about a practical way that you can ensure that your healthcare desires are respected in states of emergency, so advanced directives. And with that, I think we can actually just start talking about the agency. So Inland County's Legal Services is one of the oldest and largest civil legal aid agencies in the region. We've been around since 1958. We service folks living in Riverside and San Bernardino counties. We have several eligibility criteria that one would need to meet. There are a lot of exceptions, so I always tell folks, do not immediately discount yourself from our services. Our trained intake specialists will make sure to ask all the right questions to ensure that you are, at a minimum, walking away with free legal information, but for the most part, walking away with free legal services, which may entail direct representation, right? So in terms of eligibility criteria, folks need to be living within our service geographic region. So if you're in Riverside or San Bernardino counties, you're fine. The second is citizenship status. So you need to either be a U.S. citizen or an eligible non-citizen. I don't want to bore you with the nuances and all the caveats that exist in that second category of or eligible non-citizen. Again, our intake specialists are trained to elicit that information, right? And the third, which again, there are several exceptions, but generally we serve folks living at or below 200% of the federal poverty line. Those are figures developed by the federal government, right? The Department of Housing and Urban Development. It's all contingent on your household size. So again, our intake specialists will ask all the right questions about your gross monthly income, any benefits that you're receiving, expenses that you have on a monthly basis, collecting information about your assets. What I want to reassure everyone is that when you go through the intake process, all the information that you share with us remains completely confidential. What does that mean? That means that we cannot share with that information with anyone or a third party outside of Inland County's legal services. And if you ever have any concerns, again, you can ask the advocate that you're speaking to just kind of provide that reassurance, right? So what you're seeing on the screen is a list of all the services that we provide. We are an agency with 8 different practice groups. What does that mean is each practice group has a specialty, a legal field specialty. So just kind of going down the list. Again, I really want to encourage folks to visit our table outside, many flyers and pamphlets that will do a much better job in articulating the services that we have. Alternatively, if it's possible, I encourage you to visit www.inlandlegal.org. Each practice group has done a tremendous job in creating a thoughtful, intentional mission statement, delineating its services, etc. But just brief overview, we do have an elder law team that principally assists folks with elder abuse defense, estate planning, any and all related consumer issues, the list goes on, right? We have a health law team, which Mara will probably shortly talk about the services that they provide. We have a public benefits and special education team that assists folks with securing means-tested public benefits. We have a consumer law team, housing team if you're experiencing eviction and or any other landlord-tenant issue. An immigration team that assists folks with both affirmative and defensive immigration relief. And I'm speaking very fast, so please feel free to slow me down. I'm just cognizant of our time constraints. We do have a tax and bankruptcy clinic, which I believe is self-explanatory. We have a family law team that assists principally survivors of violence and intimate partner violence in a number of different family law issues, right? Obtaining restraining orders, dissolutions of marriage, aka divorce, establishing paternity, etc. We have a systemic impact litigation team which deals with much larger issues affecting subsets of the community. A small business clinic which assists folks with a variety of small business related legal issues, right? For example, I want to say determining what kind of entity you want to be if you have a small business, right? That's one very minimal example of all the services that they provide. We have our LGBTQ plus services program, which we highlight the name and gender marker change clinic, but I think that in speaking to the conversation that we were invited to today, we also have an LGBTQIA plus advanced healthcare directive clinic. So I'll talk about that later on, but if any and all of you are interested in receiving that kind of assistance, you would likely be interacting with me in some capacity. So I hope my face serves as a familiar reassurance when you're going through that intake process. We have an expungement clinic, that assists folks with criminal record clearing, right? And I'm happy after the presentation, if folks have immediate questions about the services, please come find us. There are several of us from ICLS here that can answer those questions. But with that, I'm going to actually pass it off to Mara, and we can switch spots if you like.
In the middle. Okay. Hi, everyone. Okay. So like we said, I am from the healthcare team at Inland County's Legal Services. We really do anything related to healthcare for health consumers. So if you have Medi-Cal, you have Medicare, you have private insurance, come to us. If you're having an issue, we can probably help in some way. Today I want to talk about your rights as a health consumer. So when you feel something's off, something's wrong, you're not getting the care you deserve, there are ways that we can try to remedy it by talking to our health plans, and if needed, escalating it further than that. So just to give you some idea of the types of matters that can lead to an escalation, you can have a quality of care complaint, you can be waiting too long to get an appointment, your plan says the closest doctor is 120 miles away, or you can have something that's more formal. You can have an adverse benefit determination. You can get a notice saying you are not covered for this specific surgery, it's not medically necessary, whatever it may be. An escalation of these issues fall into two different categories. The method of appealing is relatively the same. A complaint or a grievance would be something in the quality of care, rudeness, that type of issue, and then that adverse benefit determination would be the more formal appeal route. Okay, so once you have something you're upset with, something went wrong, you're not getting the care you deserve, how do we go about it? The first step is an informal step. It's generally talking with your doctor, talking with the provider, anyone who you've had that interaction with. It eliminates any middleman. It's usually the first step we would take as well. See if you can just informally resolve that matter. If you cannot, we would go to a more formal appeal. Step one is an internal appeal with your plan. So if you have Kaiser, you have Blue Shield, Molina, Humana, we would first file a complaint or a grievance or an appeal with the health plan. They have about 30 days to resolve it. If they do not resolve it for you, you can go to an external appeal, and then you would appeal with the agency that oversees your health plan. In most cases, that's the Department of Managed Healthcare. It may be California Department of Insurance, CMS if you're on Medicare. And then if you have an issue with negligence or discrimination, there's some alternative methods there that are not the classic appeal with Department of Managed Healthcare or your plan. Okay, so now moving on to health privacy laws. It's always top of mind. We share very sensitive private information with our providers, and we expect and deserve it to remain private information. So in California, your health information is protected by federal law and by state law. The federal law is HIPAA, which I'm sure you've heard of. It's kind of the most known name for health insurance or health care privacy. HIPAA dictates when providers and covered entities can access, use, or disclose protected health information. The California law, which generally mirrors HIPAA but has some extra more strict standards for providers to meet, is called CMIA, California Confidentiality of Medical Information Act. Like I said, it really mirrors it in most senses. You can look to HIPAA or the CMIA, but there are some differences we will speak about. Okay, so the big thing with HIPAA is that it only applies to covered entities. So if you share your health information with your landlord and your landlord goes tells someone else, that's not HIPAA. HIPAA only applies to healthcare providers, health plans, and health clearinghouses, so the entities that basically transmit billing information. This is where California has an exception that makes us a little bit stricter, and it's more beneficial to health consumers. The term healthcare provider is much broader in California. So this includes any business that offers software or hardware, including mobile apps, designed to maintain medical information. So you could think of this is probably most common with, for example, apps that track maybe menstrual cycles or other health-related information. Those entities also are bound by these privacy laws. And then only what's covered is protected health information. So that's basically any of your health information that can identify you. So your doctor is free to say, I see, patients who had cancer. but they cannot also share any of that information if it in any way identifies one of their patients or another person. But there are permitted uses and disclosures of DHI. Usually that's just to the individual, to people they have approved to have access to this information. There are some exceptions, not too common, or at least not common for the average consumer who may be having an issue. So if your doctor, your provider, your nurse, anyone, maybe has shared some information or you suspect a HIPAA violation, what can you do? Under HIPAA, you can file a complaint with the Office of Civil Rights. There's an online portal. You can also, there's a couple other methods. You can mail, fax, email. This is done by filing a complaint. That's the only way you can remedy a HIPAA violation. However, in California, CMIA offers a private right of action, meaning the individual who has been wronged can sue their provider and can seek a remedy for the violation of the privacy. And I think we're now on to directives.
Yeah, that was fast. So if folks have, it was very generalized overview information. If folks have questions, please feel free to interject. I see a few hands. And
you want to go already?
Yeah, I think it'd be best before we move on to directives.
Sure.
Just a question about HIPAA. Yes. Employers covered by that as well?
The employers for any employer at your doctor's office, for example.
No, just say your work employer, your HR department.
There are privacy laws related to that, but HIPAA is. Let's go back to the. Can we go backwards?
Yes.
So HIPAA specifically covers these private entities. So your employer would not be part of this, but there are other privacy laws that I am not can't speak on related to specifically the health privacy laws. But I'm assuming there are other laws there that regulate privacy.
Had employers say they can't do that because of HIPAA. So.
Okay.
And my other question is, what's the difference between a grievance and a complaint?
Sure. They're basically the same thing. We have different names for them. Basically, the grievance, complaint, and appeal, the process is the same. When you go to your health plan, that initial step, and then if you need to go to a second step with the external appeal with the agency, you will express what the matter of the issue is, and then depending on what that issue is, it will be funneled into the right direction. Is this a complaint and there's a certain timeline for resolving complaints, or is this an adverse benefit determination and appeal that requires a determination of is that medically necessary, and it's a more complex resolution.
What sorts of remedies do you see? Just generally.
For what type of issue?
Like for a grievance, something more formal like a grievance, either for HIPAA or your CMA.
So if a grievance and appeal, a grievance in this context could be something like
what sort of remedies do you see?
Right. So if it's for example, your provider, your plan says you can only, the closest doctor is so X miles away and it's too far, it's outside of that distance, they would be required to find you a doctor that is within a certain geographic region. If it's a rudeness issue, they may send training to that physician. HIPAA, under HIPAA, you do not get a remedy as an individual. If you look under state law, for that privacy right, you would then, there are damages and remedies you can receive under state law, but not under HIPAA.
Okay.
Yeah.
So, there you go. I volunteered at Cedar Sinai for 4 years, and we had 2.5 days of HIPAA training. I'm just kind of curious, there's so many people in this community volunteer. What the exposure is. Hopefully the healthcare organizations can explain it to them, but what is the ramifications if you are a volunteer in a healthcare organization, doctor's office, if you share? Because I know they gave us very specific things like they're fined $10,000 others and end up in jail for 10 years. So I think because we have such a philanthropic community of people who volunteer, it's a good thing to maybe touch on.
If you are a volunteer at a provider's office that is bound under HIPAA, that volunteer is too. And then if there's a violation or a breach of the HIPAA privacy rule, and someone files that complaint, the provider would be the entity that is fined or given penalties in some way, not the individual, unlikely the individual volunteer, but it would be the provider's office.
Any other questions related to please?
So what are the statute of limitations? Here. Specifically for HIPAA, I think we have it on here. It's 180 days? 180 days for HIPAA.
Yes, so for HIPAA, you have 180 days from the violation to file that complaint. I do not know what it is, the timeline for California. But if you reach out to us, we can get that for you.
Any other questions? That was a great also question, Ron. Just to reiterate Mara's point, if we are unable to, you will come to realize that attorneys are very hesitant to provide information that they are not firm or concrete about. So if we were not able to respond to your question, again, please give us a call, because at a minimum we can provide you with free legal information rather. So that would be in response to whether or not the employer is bound by CMIA specifically, right? Or the statute of limitations for filing a complaint for a violation of the CMIA. So really just want to encourage you all that there's other folks that can hopefully provide that response at the agency. With that, I think we're going to start transitioning over to, if you can take that, right, if you don't mind. I'm going to start transitioning to talk about a practical way that you can ensure that your healthcare desires and wishes are protected, or safeguarded rather. How many folks here know about an advance directive? Well, that's great. How many folks have an advance directive? Okay, so a little less. Maybe, and my hope is that you walk away from today's presentation with the motivation, if you do not have an advance directive, to create one. And if you have one that was established years ago, or your needs have changed, to revisit that, right? So for folks that don't know what an advance directive is, right? An advance directive traditionally has two components. One is the living will. The second is the durable power of attorney, right? So the living will is actually the section of the directive that allows you to outline your healthcare desires, whether that be the choice to prolong your life if you are in a medical emergency or not to prolong your life, the choice to delineate if you do, for whatever reason, end up passing away, what can happen with the disposition of your remains. Are you going to donate to a particular agency for a particular reason? That allows you to designate that kind of information. It allows you to also outline what kind of life-sustaining treatment you'd like to receive, if any at all, right? And there's so much more that you can bake into a directive. I typically have these conversations with TGI individuals, so individuals who are transgender, gender diverse. And a lot of folks have concerns about, well, I want my medical care team to respect my identity. I want them to refer to me using my lived name, using my pronouns, etc. So that's just a tangent, but an example of something else that you can include in the directive, right? Outlining how you wish, whether you wish to be buried, whether you wish to be cremated. And I understand that these are very difficult conversations to have. And likely very difficult conversations for your loved ones to have if you are in a state of emergency, right? And if you are in a point in your life where you cannot advocate for yourself, having this directive really allows you to outline these wishes and have someone effectuate those wishes. Which leads me to the second portion of the directive, that durable power of attorney. So that portion of the directive allows you to designate one or multiple healthcare proxies. A healthcare proxy is someone that is empowered to make healthcare decisions on your behalf in the event you are incapacitated. So it's important to remember this person that you designate or these people that you designate cannot effectuate those wishes until a medical provider has determined this person cannot make decisions on their own. So there technically also is a way that you can allow a healthcare proxy to start making healthcare decisions immediately. We discourage that typically, but we will have a more nuanced conversation, right, if you come to us letting us know that you want to create a directive. But some just housekeeping remarks about the durable power of attorney. We really encourage folks to have someone that they trust become a healthcare proxy for them, right? Someone who is familiar with your health situation, with your morals and your values, because ultimately this person or people are the ones that are, again, going to act on the directive. And I have a few points about just kind of really reaffirming and wanting to take part in this like cultural shift. Everyone should really have a directive, right? But most importantly, older adults, individuals living with serious medical diagnoses, right? Folks that might be disproportionately more in the possibility of experiencing a medical emergency. And that was a lot of word, like what I was trying to communicate is, again, if a person there's a disproportionate possibility of them being affected by a medical emergency, that's when we really should be having a serious conversation about a directive. I want to also let you all know that you do not need an attorney to create a directive, right? Maybe a peer support navigator, maybe a healthcare professional where you typically receive your healthcare is able to walk you through these forms. They're standard template forms for California, and they're very intuitive, right? They kind of guide you in filling it in. Where an attorney does kind of come in is provide additional context, right? But also to help you actually execute the directive, right? Because there are various means by which you can execute the directive. So I'll get to that shortly. Any immediate questions about what an advanced directive is? Perfect. Here we have again, right, advanced care planning is not only for older adults, right, and for those living with serious medical diagnoses. A medical emergency can happen at any point, at any point in anyone's life. So someone will be dealing, your loved ones will likely be dealing, right, with the emotional repercussions of seeing you in that vulnerable state. Having a directive just kind of makes sure that a person has a game plan for how to make sure, so that they can make sure to respect your wishes, right? Yes, and I guess I should encourage you all to have very serious conversations with your doctors. Your doctors can also not only enlighten you about your own state of health, right, as they should be doing, but they can be your partner in helping craft some language to make sure that, again, you're receiving all the care that you need while incapacitated. Okay, so here's just some standard items that we encourage everyone to have when creating a directive. The first, choose someone that you trust. It need not necessarily be a blood relative. It can be your chosen family. It can be a friend that you are very close to, that is very aware, again, of your morals, values, healthcare, desires, and wishes. It can also be your spouse. It can be a blood relative. Under California law, there is no exact order as to who would be an agent, but we typically start from spouse, then with blood relatives like parents, children, grandparents. But again, your healthcare agent or agents can be anyone that you trust, and again, that likely is in a position to help effectuate the directive. They may not necessarily need to be there in person, but they should be able to pick up a phone and answer the doctor's questions, right? And I know that that's a big concern for a lot of folks. Maybe we don't have someone in our immediate vicinity that can show up if I'm in the hospital. But again, that person need not necessarily be there physically. They just need to be able to answer the call, should that ever happen. We recommend having multiple agents, or at least an alternate agent, in the event the first person is not easily accessible. That way the doctors don't have to wait around trying to determine what's the best course of action. I will say you do not need to have a healthcare agent. You can still have a living will component to your directive, right? At that point, the healthcare team will do its best to follow the care that you have delineated. But it really is best practice to have someone that can advocate on your behalf, again, if you aren't able to do so on your own. A lot of folks are always concerned about, well, is this healthcare agent going to keep being able to make decisions on my behalf? You can always revoke the power that they have in making those kinds of decisions, right? It's best practice to routinely update your directive. Relationships tend to change, right? Naturally. So again, make sure if you have a directive, keep updating those. The second point is tell your agent where your directive is located. It's best practice to give a copy to your healthcare agent, to your healthcare provider. There are actually repositories that exist that you can pay to upload your directive that then a hospital or your medical provider can access, but that's an added cost. That's only in the event, again, that your healthcare agent doesn't have the copy. We recommend folks carry either a digital copy on their phone, a physical copy in their backpack, their purse, in the glove compartment of their car. So many different ways that you can ensure that your healthcare team will know what your wishes are, right? Yes, so the third sub-point we have here is that you can include language in your directive, directing that the agent doesn't disclose private medical information to specified individuals. I included this as just kind of, again, the recognition that familial and personal relationships change, and you may not want certain people to have access to this information. Again, for LGBTQ individuals, this is particularly important, right? Unfortunately, sometimes we do not have affirming family, blood relatives, and we do not want them to have access to this information. We don't want them to visit us in the hospital because that is too traumatizing or re-traumatizing, right? Again, that is language we can bake into the directive. The last, again, is to just talk to your healthcare providers, make them a partner in crafting the directive so that they can provide additional guidance. It is a lot of pressure to have these conversations on your own or with your loved ones. Sometimes having that medical provider, that neutral third party, can help facilitate crafting the directive. Okay, so this is just a generalized way that you can access or contact us for more information. We have our general intake line. We have a senior intake line for individuals age 60 and up. We have our website. We have 4 great individuals here that you can talk to. But I also want to pause and maybe answer any relevant questions as they relate to the advanced directive portion.
Does the general power end when you die?
So that individual will still be empowered to designate it in the directive to make decisions about the disposition of your remains. However, you can have very firm, concrete language that their power ends when you pass away, and you can designate someone else to make those decisions for you. Any other questions? I'm going to take that as a positive. That is it on our part.